Hello, everyone, and welcome to today's SNRS inaugural webinar, an interview with Dr. Marilyn A. Ray, presented by the Qualitative RIG. I'm Jennifer Lanfear, the account coordinator for SNRS, and we're pleased that you could join us today. Before we get started and hear from our distinguished speaker, you'll be seeing the SNRS splash screen or the presenter's slides while I go over a few housekeeping items. Your phone will be muted automatically in consideration of our presenter and your fellow webinar participants. Please use the chat feature set to organizers and panelists only to send in your questions, or if you need to let us know that you're having technical difficulties. All questions will be saved until after the panelist has spoken. And also, please send in your questions as we go instead of waiting until the end. At the conclusion of today's presentation, you'll receive a webinar evaluation via email. We encourage you to provide feedback so we can continually improve the SNRS webinar program. You will also receive a link via email to the recorded broadcast of this webinar and to the slides. Our moderator today is Dr. Shirley Gordon, professor at Christine E. Lynn College of Nursing, Florida Atlantic University. I'll turn the webinar over to Shirley so she can introduce our panelists and get us underway.
Okay, welcome everyone. We're having trouble advancing the slides. Yeah, they're not going.
Okay, let me turn you over as a panelist one more time. There we go.
Okay, now we've got it. Okay, I'm Dr. Shirley Gordon, and I'm the former chair of the SNRS Qualitative RIG. And I am the founder and director of the Head Lice Treatment and Prevention Project at Florida Atlantic University College of Nursing. And I'm a colleague of Dr. Ray's. And I want to thank you for joining us today on the inaugural webinar for SNRS and the Qualitative RIG. This webinar is an initiative of the Qualitative Research Interest Group. And the goals of this group are to promote the qualitative methodology with an agenda of furthering awareness amongst SNR regarding rigor and scholarly work, and of course to provide a mechanism for mentorship of qualitative methods and networking opportunities, and this webinar meets both of those goals. Our speaker today is Dr. Marilyn Ray. She is a member of the college here at Florida Atlantic University, and she has an esteemed career in qualitative research and nursing practice. I'm going to let her give you a few highlights of her career.
Thank you so much, and welcome to our webinar. We're delighted to be participating with all of you in this inaugural webinar for the SNRS, and I'm so thankful to be chosen as one of your first speakers. So because this is a qualitative research presentation, I think I'll just give you some highlights about my background in qualitative research. I am at the Professor Emeritus here at Florida Atlantic University, Christine E. Lynn College of Nursing. I'm also a retired colonel in the United States Air Force Nurse Corps. I was in the Air National Guard, the Air Force Reserve, as well as active and reserve duty for 32 years and retired as a colonel. And my faculty positions, other than the current one I have, are from the University of California, San Francisco, University of San Francisco, McMaster University in Canada, and the University of Colorado. And so that this focus that we're going to be sharing today is on the theory of bureaucratic caring. So I'd like you to know that I'm one of the founding members of the International Association for Human Caring, and was in the first group who all met together, about 10 of us, in 1978, after Dr. Leininger declared that caring is the essence of nursing. So I am a mentee of the late Dr. Marilyn Leininger, who is the founder of transcultural nursing and the qualitative methodology of ethno-nursing based on ethnography. And another area of mine is I was on faculty. I was a junior faculty instructor with Barney Glaser and Anselm Strauss, who are the founders of the grounded theory method. They are sociologists who are grounded in symbolic interaction and began to see how the we as researchers could share our knowledge about social process. And I'm also a classmate of Dr. Janice Morse, whom many of you may have read many of her works on grounded theory and qualitative research. She is the founder of Qualitative Health Research as well as the Global Qualitative Nursing Research, and I am a board member on both of those organizations. And Dr. Holly Wilson was one of the first nursing scholars who did grounded theory in the 70s, as well as earlier Jean Quint Benalil and Phyllis Stern. So the three of them are considered the nursing founders of grounded theory in nursing. I'm also a colleague of Dr. Max van Manen, who is a primary phenomenologist here in North America. He's originally from the Netherlands. And I did the first caring research study in the US, which resulted in the discovery of the theory of bureaucratic caring, which I'm going to speak about today.
Okay, thank you, Dr. Ray. Of course, our interview today does focus on your theory of bureaucratic caring. Can you describe the origins and evolution of the theory of bureaucratic caring for us?
Yes, and thank you. Well, I was a doctoral student in transcultural nursing. I actually was Dr. Leininger's first transcultural nursing doctoral student in 1977 to 1981. And so my focus I was always interested in culture and had done a couple of other research projects of studying organizations as small cultures. And so for my doctorate, I decided that I was going to continue with this research and with more knowledge of anthropology, more knowledge about transcultural nursing, I was interested too in studying the meaning of caring in the organizational culture. And so that was the focus of my research question. Interestingly, in today's world, I'm not sure we could have one research question such as what is the meaning of caring to you, but at any rate, I had one central research question. And because I had studied ethnography in the past, I also had Dr. Leininger as a professor, so I had a background in ethno-nursing, which is the study of cultures, you know, the idea of studying the whole phenomena of, for example, organizations as cultures. And then I also had the opportunity to study phenomenology, which is the study of the lived experience, the meaning of the lived experience. And then I was interested in generating theory. So you can imagine at the latter part of the 70s, theory development from research was not prominent in nursing, and not many nurses had been engaged in doing grounded theory. However, I wanted to incorporate all these methods, and which was quite a phenomenal task, and generate theory. I didn't know exactly how it would advance. My professors, my committee members in my doctorate also didn't know, but I decided that this was my passion. I wanted to study caring. I wanted to study complex systems. I actually, you know, maybe to other people who may not be fully committed to organizations, I did believe in organizational context and how important they were to nursing practice. So that was the focus of my work, and through the integration of these three different methods, ethnography, the study of the organizational culture, phenomenology, the study of the meaning of the lived experience of the participants who engaged in my study, who were more than 192 direct interviews, and then also the generation of grounded theory, both substantive and formal theories that I was going to generate in this work. So through conducting the research and gleaning all of the data about the meaning of caring, I began to see that caring was moving beyond what I had originally thought about caring as more a transpersonal and maybe even a transcultural relationship to the idea of caring being informed also by the culture, the organizational culture, as well as roles. So when I interviewed in different places and did participant observation, for example, in ICU, the dominant caring characteristic came out as more technologically oriented. Or when I was in the oncology, the dominant caring characteristic was more associated with the spiritual ethical. And then in the medical surgical or administration, it was more associated with the political. And definitely when I interviewed the administrators, both nurses and non-nurses, the economic perspective came forward. So it was a turning point for me when I asked the CEO, what is the meaning of caring to you? And he said, caring is maintaining the economic viability of this institution. If I don't maintain the economics, then you wouldn't have a place to work, nor would our patients have a place to come for their care. And that was definitely a turning point for me. I began to see how the context played a significant role in our understanding of caring. And so through analysis, and I had to do quite a bit of trying to figure out how to classify this information. For example, when people spoke to me about caring as compassion, empathy, love, or they spoke to me about it as providing safety or other concepts, I tried to then look at the actual lived experience and the words of the lived experience, and then determine how I could build a structure of caring. And so you can see on the slide that the original grounded theory showed caring in the center with its interplay with political, legal, technological, economic, ethical, religious, humanistic, and educational. And in this model, you can see that political was and economic were very strong. And when you think now, 37 years later, when this work was accomplished in 1981, that we are still dealing with the significance of these major arenas. Probably technological would be a little bit more expanded. So then I have, since my doctoral research, I have done additional research. So I want to go back and talk about the theory development. The grounded theory itself has two theoretical perspectives, one being substantive or substantive, which means that data are generated from the social world, from the social process, from what the meaning is within the intentional consciousness of participants. And then, so the substantive forms the groundwork or the grounds for grounded theory. And then the second evolution of grounded theory is called formal theory, whereby one would take the data from the substantive areas and how that is classified, and then integrate it with arguments that are associated with the social world itself. And so that's how the theory of bureaucratic caring came to be. So I'm going to reverse a little bit back again and talk about the development of the theory. The first phase of the substantive theory I call differential caring, which meant that caring was differentiated, like I said, by role, by the way people understood it within different units. But most people had a universal about helping people. Empathy was a dominant modality, you know, in terms of understanding caring, but they described it more according to their role, whether they were a charge nurse, a staff nurse, a nurse manager. And you can see that a lot of the concepts advanced. Say, for example, nurse managers began to talk more about administration, about budget, about the political arena, and things of that sort. People in ICU talked about the technology, and in those days we didn't have social media and, you know, computer-assisted communication like we do today. However, it was still a major force in ICUs, step down, operating room, emergency departments, and things like that. So I'm going to move on now to, maybe I can go to the next slide. So you can begin to see how this theory has taken shape. That first, you know, looking at those differential caring concepts that have been formulated into a structure, such as political, economic, technological, legal, spiritual, ethical, physical, educational. And then what I did was to take the thesis of caring and began to look at the elements of the bureaucracy, and so, or the system or the organization. And so that is how I actually gleaned the term bureaucracy. I went back to Max Weber's work in the 1920s, who's considered the father of bureaucracy or complex systems. And so I looked at that Hegelian perspective of the thesis of caring in relationship to the antithesis of the bureaucracy, and or those phenomena associated with the bureaucracy, which would be political, economic, legal, technological, and then in Hegel's perspective or philosophy, the idea of thesis, antithesis, synthesis. In the thesis and the antithesis, the idea is what he called the negation of the negation. Both of those concepts negate out and the phenomena are synthesized. So that's how the idea of the formal theory of bureaucratic caring came into existence. And that is how I presented my argument in my doctoral dissertation of using the ideas related to caring as more humanistic and spiritual ethical with respect to the antithesis, the system concepts, and then synthesize those particular ideas into the theory of bureaucratic caring, or what is called the formal theory of grounded theory. So just a synopsis again, that grounded theory has the substantive theory, the original theory that is grounded in the social process and in the meaning of experience, and then the formal theory, which is developing a little bit stronger and more deeply relative to the social world and using other concepts or other ideas or other philosophies to strengthen the argument. So this is just another way of showing the model again with the structural components. But now I've put centered spiritual ethical into the center because subsequent research over the last 3 decades, or when I generated the notion of spiritual ethical in the center, began to show me that most of the research I was doing, for example, in ICU, step down, economics, everything had an ethical framework. And then I decided that the spiritual component was more, rather than just specifically a religious notion, that it was a creative component, and how that creativity began to come together to, you know, from what Bar-Yam says in complexity science, how do we make things work? And so the spiritual ethical perspective was moved into the center, and then there is the interplay between spiritual ethical caring and technology, economics, political, socio-cultural, educational, legal, and the physical, which includes, you know, the body, mind, and that perspective. And then how that theory then shows the healthcare system and the institutional culture of an institution, or this work is also being used in public health, so it could be in public health. It's used in correctional facilities, and then the society at large. And then there is that interplay between the microcosm of an institution and the macrocosm of the societal culture.
Okay. Thank you, Dr. Ray. The models provide a visual depiction of the evolution of your theory over time. We evaluate theory by looking at its usefulness in guiding research and nursing practice. How has the theory of bureaucratic caring been applied in research and practice?
Well, from my own research over the years, I have done research in economic, in those contractions, you know, spiritual, ethical, economic caring, technological caring. Other scholars have done work in legal caring. I've also have a strong background from my anthropology degree in political anthropology and political culture. And so looking at that, and as we are moving now into our own nation, developing our, for example, the disputed, perhaps at this moment, the Affordable Care Act, we're beginning to see all of this evolution of the political and economic in the context of healthcare that impacts definitely the patient and the family members and the community, but it also impacts nursing and nursing practice. So my own work has been studying those particular phenomena, and Dr. Marian Turkel has been a colleague of mine since 1991. And so she also did a study on the economics of caring. And she and I have worked together with funded research from the Uniformed Services University of the Department of Defense, studying relational caring. We've studied some major institutional work within the military tri-service nursing research program, as well as the TRICARE for Life program, which guarantees health care for all military personnel and veterans. And so I've done a lot of research in there and won some research awards for that particular work, and also facilitated the change in policy, which was a major effort in, you can imagine, in the United States Air Force. And as you know, the military is one of the second largest bureaucracy in the world. So, so this idea of being able to develop a lot of changes in the military healthcare system has been very important to me. And also I've done a lot of work in workplace redevelopment, how we can change the workplace by virtue of understanding our work, our caring work in the context of these systems and these concepts like economics, political, technological, legal, all those things that affect nursing practice. And so currently my work, I've had that original trans-theoretical evolution also in nursing education, but now in the United States Air Force in primary care and studying clinical and economic outcomes. And my colleague in the military, Colonel Marcia Potter, has done a major study that has not only improved clinical outcomes for diabetes outcomes, as well as economic outcomes to the tune of over $2 million, or if it moves into all of the service areas, it might be in the billions of dollars of savings. So you can see that nursing is making a big impact on not only improving outcomes for clinical issues, but also for economic issues. And then the current study that's going on in the Air Force right now is the development of an interprofessional practice model. And that work has been approved by the U.S. Air Force for development, and also some work in the Veterans Administration.
That is a really impressive body of work. Okay, we're not advancing again. Jennifer, can you help us with that?
So just to, keep sharing what I'm showing here, I feel from my own experience, is the fact that we have the opportunity to be able to be successful in nursing by by grounding our work in research, and then by continuing that research, and then what I feel is trying to be confident and courageous about how we share our research and get it into very important contexts where patient care can be improved. So this particular model just again shows this trans-theoretical evolution of caring, where we're now developing, for example, my colleague Marion Turkel and I, this relational complexity theory model, which integrates the grounded theory of bureaucratic caring with the sciences of complexity, and identifying those major concepts such as interconnectedness, dynamism, even concepts like uncertainty, and how do we bring that forward in our development for improving patient care. And then our workforce redevelopment, which I feel through research and through knowledge about complex systems, we can definitely make things work and improve patient care and our work life.
I know you've touched on this a little bit already, but moving forward, what do you see as the future of the theory of bureaucratic caring?
Well, what I feel now in my career, and as I'm growing a bit older here, this theory has actually taken off. When I first developed the theory, we were more interested, I think, in the transpersonal relationship, and we hadn't focused on how the institutional context, whether they be hospitals, public health agencies, schools, where we have healthcare for children, or prison systems, or any of these complex systems, how they play a role in understanding the meaning of caring, and subsequently how we can improve the care and well-being of our mission, what our focus is. And so this work has been successful in those areas, as well as now with this military model, which you can see on your screen. There is the star, which is the central symbol of U.S. Air Force, and you can begin to see the concepts from the theory of bureaucratic caring, and then the concepts identified by the U.S. Air Force healthcare system or medical service about zero preventable harm, trusted care, caring communication, and partnerships. And in this model, you can see the various aircraft that we use for aeromedical evacuation in the U.S. Air Force. The now retired C-9 Nightingale, the C-141, which has been the workhorse of the Air Force, been in since the 50s, still being used, and now the C-17, the new aircraft that helps to bring our wounded home from Iraq and Afghanistan and other places in the world, and then our helicopter services. So we wanted to put a space rocket in here to show that the Air Force also was space, because it's called aerospace. However, the model was already quite busy. But you can see the next evolution for healthcare in the future, as we know, with research going into space, going to Mars, and then perhaps developing a colony on the moon. So we have a lot of things in nursing that we can be proud of and be just on the journey and actually developing that journey for our society and our universe at large.
That's very exciting, and the theory of bureaucratic caring is going to lead the way, all the way to Mars.
I see. Well, it's a bureaucracy, as you know. It's controlled by a bureaucracy in the U.S., And it's like you're married to a technology when you're in space. You're totally...
Your life depends on it.
Yes, you're totally wedded to it. Now, granted, you could be on the planets themselves or the moon, but you still, I think, need to get from here to there, or maybe sometime you might want to come home, right? And
right.
So,
all right, this interview with you, thank you so much. It makes me want to go and read everything you've written again for the first time.
Oh, thank you so much.
And this is this is an initiative of the Qualitative Research Rig. So one of the purposes of the rig is to promote qualitative research. Mm-hmm. So based on your vast experience, what do you see as the future of qualitative research, and what advice do you have for nurse scholars?
Well, thank you. Well, as you know, and those of you who are listening are who may be both qualitative and quantitative researchers, over the years, often the qualitative research, because of the focus on funding with the National Institutes of Health or the National Institute for Nursing Research, often the focus has been on generating another language called numbers. And so qualitative research has verbal language and communication, and quantitative has the numbers. So I think that we need qualitative research. We need understanding of human experience. We need understanding of social processes associated with our work in complex systems. So qualitative research will always be important. And for myself as a philosopher of both the inductive modality as well as the deductive, the quantitative, a lot of people over the years have said, well, these two methods, how could they come together in terms of mixed methodologies, which seems to be the focus now of research for funded programs, and which is still to some extent problematic, because inductive deals with the generation of knowledge that comes from the human experience or from the real world, so to speak. And quantitative research are, designed to test hypotheses and generate quantitative outcomes using different modalities of quantitative research. So, but in some of my own experience, I've reconciled these two areas by two different arenas. One, through generating more knowledge about interpretation. How do we interpret the interrelationship between numbers as a language and words as language? And generally, I felt that we interpret through language. In studies that we read, for example, the interpretive phase, even in quantitative studies, is reconciled through linguistics as opposed to more numbers. So in some of my own work, I worked with Dr. Davidson. We did a mixed method, and we reconciled the quantitative and qualitative perspectives on the study of complex systems through hermeneutics, through interpretation, and seeking understanding and deep understanding through, again, that almost like seeing the qualitative maybe as a thesis, the quantitative as the antithesis, and bringing them together with a new synthesis. So that's how I have reconciled some of those differences myself to understand them philosophically. And then I took a workshop last week in Santa Fe at the Council on Nursing Anthropology and the Society for Applied Anthropology Conference on rapid qualitative inquiry. As you know, team research is considered the dominant domain now for generating knowledge or research knowledge. So I wanted to find a way, how do we develop team research in qualitative inquiry? I know we've used it in focus group and probably critical participatory research, but in general, just qualitative. So I learned quite a bit from that, and Shirley reminded me that often the way we think determines how we're going to work as researchers, whether we should work individually or in teams. So because some of us can generate our knowledge by individual research as opposed to working with others. So these are the things I think that are forthcoming and we have to learn. And then in terms of grounded theory, I think we have to make sure that if we're going to choose this theory or method, we need to generate theory. I know that some scholars feel that you don't have to generate theory, you just generate categories, but I'm one that if we're going to select this method, that we generate theory, maybe not all moving into formal theory, but certainly substantive theory. And the other area is we have to publish our work. There's, our work, as a doctoral educator myself, I told my students or tell them their work isn't done until they publish their work. And then from there, then it's disseminated and other people can see how it's being used and then it generates itself often. And then, of course, complexity science, it's not new. It's probably as old as grounded theory, I think. But this idea, what does complexity science mean? And complexity science means it's a science of quality. So here we have qualitative research that somehow is not always integrated in research, but our science says that it's a science of quality, interconnectedness, human environment intergality, dynamism, patterning, and things like that. So we can see some of these paradoxes that are occurring in science and research. And so those of us that are interested in this as educators, researchers, we have to be able to communicate about how we use the science as a general science, and then how we use research, and then how we can understand the distinctions and the similarities.
Okay. Thank you. That concludes our interview for today. Dr. Ray, thank you so much for sharing your incredible wealth of knowledge and skill and expertise in qualitative research, and the things that are on the horizon for the theory of bureaucratic caring are so exciting. I can't wait to hear more about what the Air Force ends up doing with your model. That is, again, so exciting. We did provide some references for you that are numbered throughout the slides. And in addition to the references that we used in the presentation, we also provided some recommended readings for those scholars out there that really want to dig a little deeper into Dr. Ray's theory. These are Dr. Ray's primary works in the theory of bureaucratic caring. And we have a couple of acknowledgments. We want to thank our IT department, particularly Inder Viola, for helping us with the PowerPoint presentation, and of course Dr. Sherilyn Kaufman, who's the co-creators of the models that were used in the presentation today, and as Dr. Ray mentioned several times, Marcia Potter, who's a colonel in the U.S. Air Force. For more information, you can also go to Dr. Ray's website. And now we'll open the presentation to any questions that you might have. Okay, so if you have a question, you can go ahead and type it in the chat area. We also have our email addresses here, so if you have questions that you would like to present to Dr. Ray or myself, you can contact us directly.
Would anybody like any clarification on the theory development? For example, my initial theory of the substantive theory being differential caring, and then also this development toward formal theory. maybe your own experience has identified, if you've done grounded theory, perhaps you've done substantive theory and you'd like to share that theory, and I could respond to your own theory and your own questions about the theory. And those of you know that there's quite a few.
Okay, we do have a question coming in.
Oh, good.
What suggestions do you have on where to publish implementation studies?
Well, thank you for that question. As you know, many of our journals, for example, Advances in Nursing Science, has themes. So if there's a theme or a little, what I would call a kind of a relational perspective about a theme, we should be trying to get our work into what we consider our central journal, which is Advances in Nursing Science, in terms of implementation. And then if we have any clinical studies, maybe many would like to put their work into clinical journals. And so I think in my own experience, as you know, publishing isn't easy, and going for review for publication isn't easy, because oftentimes we are rejected. Just for your information, this theory was rejected initially, and I was told that it was not a theory, even though the theory was generated from the use of qualitative methods, and especially grounded theory, to generate theory. And so that was very discouraging to me, and I'm sure it is anybody who's been rejected. It is discouraging, but we have to say, well, maybe it didn't meet the requirements of the reviewers, but we have to, kind of turn it around again and see what other journals that we can submit to. And for example, like I am with Shirley on the board of the International Association for Human Caring. We do have a journal, the International Journal for Human Caring, and so often caring, generally, they have to be caring science studies, and they are submitted there and reviewed and hopefully published. And we have the Journal of Advanced Nursing. We have Nursing Science Quarterly if people generate theory, because Nursing Science Quarterly is generally focused on theory development. And there is a call now for theory for Nursing Science Quarterly, if any of you are interested. I'm on the boards of the Qualitative Health Research, so you can submit there, and then the online journal of the Global Qualitative Nursing Journal, and both of those. And we have at our university college here, we have the Journal of Nursing and Aesthetics. And so those are some places that articles can be submitted. And myself as a nurse administrator too, Nursing Administration Quarterly, Nursing Administration, any of those journals, Nursing Economics, sometimes they like more quantitatively oriented results of research as opposed to qualitative, but we still have to make an effort and see if we can begin to help the editors and reviewers to see that qualitative adds a very strong dimension to our research and our patient care and outcomes.
Well, Dr. Ray, I love that you shared your experience of being rejected, and you're right, we all have had the experience of being rejected. And if you're just starting out, or you are just trying to publish your first manuscript, it's important that you reach out for a mentor. And mentors that have experience with qualitative research. And that's one place that the qualitative research interest group can be of help to you. That group is made up of a lot of qualitative researchers that have many, many years of experience, and we're there to help mentor young and old to help move their qualitative research along to get published and to further develop their work.
And I know in my own life, if it weren't for my mentors and the people who saw value in my work, you know, I wouldn't have this work in print or be an educator and a continued researcher. So, like you say, mentorship is so critical to our development, professional development, and certainly our research.
Right. Are there any other questions from the group?
Was there one there from
Here's
Mary Ellen?
Yes.
It does look like there's a couple questions. One from Jennifer and one from Mary Ellen.
Okay, I saw the one from Mary Ellen. Can you comment on contributing to theory from nursing and other disciplines by using qualitative research in nursing versus new theory?
Let's see, can I see that once again? On the,
yeah, it's hard, it's very tiny. Yeah. Okay, can you comment on contributing to theory from nursing and other disciplines by using qualitative research in nursing versus new theory?
Well, I think in my own career, that's what I've done over the years, is actually continue to, rather than generate new theory, although some of my research that I've done in nursing administration generated new theory in studying caring with nurse administrators specifically, and also some research in the military. So I have both the continuation of the theory of bureaucratic caring for research, but also generated new theory. And then Dr. Turkel and I developed the theory of relational caring complexity, where we began to integrate the complexity science tenets or philosophy into the context of understanding the complex system itself. So, so I think we can always use our own particular theories and continue the research associated with those to enhance our theory development, as well as generate new theory based on maybe new topics that we choose to focus on and want to generate new grounded theory from those new topics.
Great. We have another question. As a PhD student, did you identify your qualitative design based on your personal interest, or was it guided by your phenomenon of interest?
Well, thank you for this question. I think it's both, because I graduated in 1981 and I started my PhD in 1977. And previous to that, I had a degree in anthropology, which was a focus on ethnography and the study of culture. And so I was intrigued with continuing qualitative research. And when I was a doctoral student, I had the chance to study phenomenology with Dr. Hanstead, who was one of the few phenomenologists in the country who was teaching phenomenology. And so I had, and then having more of the foundational knowledge about grounded theory from early experience of when Glaser and Strauss were at the University of California. I didn't have a doctorate then, so I was just intrigued by, you know, theory or methodology at that time. So I was, I wanted to use these three methods of ethnography or ethno-nursing and phenomenology and grounded theory in my research, and I was absolutely passionate about caring as the essence of nursing. So that was what I wanted to study. And then I knew that nursing, you know, the majority of nursing practice was within hospital cultures, and it was my own experience as well as a clinician. So I wanted to study caring in the complex system of the hospital culture.
Jennifer had a second part to her question. She asked, as a first-year PhD student, I wonder how a researcher lands on a particular method, such as ethnography, phenomenology, or grounded theory, for their program of research.
Well, I think one of the responses to that, as well as you're in a PhD program with a body of knowledge that's being disseminated, and professors who hopefully are teaching qualitative research. Some professors may not have the background in all of those methods. They may be a grounded theory specialist, so that might, as a PhD student, you might be directed more in that domain. If a professor or a number of professors have a focus in ethnography or ethno-nursing or phenomenology, you may choose that. But often, just to get back to your research question, for example, ethnography is really the interest in the study of the culture, and that can be the culture of nursing, the culture of patient care, it can be the relational culture, but and culture has to do with values, beliefs, attitudes, and behaviors, so you want to see how you might study that ethnographic perspective, and generally it's through participant observation and interviewing. Then phenomenology is really looking at the meaning of the human experience. So your focus again would be the philosophical foundations of human science, which have to do with the study of, for example, the philosopher Edmund Husserl, who is considered the father of phenomenology, whereby he, critiqued more of quantitative research and began to say that we had to look at what is the meaning of lived experience. So lived experience was broader than 5 sense perception. It was all of our retentions and memory, all of our anticipations and our portrait tensions in the future within the context of the now or the lived experience. So, and then grounded theory again is, from my background, is really the study of the social and nursing process. So you're interested in terms of using these three methods: the culture, the lived experience, and the social and nursing process. So you can use all of them like I did, or you can use any of them, to study a particular phenomenon of interest for yourself. So, but as I said, and as Shirley said, we have to have the mentors who have backgrounds in these methods to begin to help us to then shape. I mean, you have a question in mind for what you'd like to study, but how to help you shape it, and then what methods are the best to use to advance ideas and study a phenomenon. So it's a complex process, but you probably have an advisor right now, so you can speak with your advisor, and you have professors who are teaching, hopefully in this situation, qualitative research and maybe the full range of qualitative research, and then you're getting inspired, and then you can develop your research question and your method, and then move forward with your own study.
And I agree with you, Dr. Ray. It's important to know the phenomenon that you're interested in studying, and then what is the state of the science on that phenomenon. What questions have been asked, what questions remain, and then what method is best suited to answer those questions. That's another way to think about how to select a specific method that you might be interested in.
Yes.
Because you'll have to defend your method when you go to present your dissertation. Maya has a question. Do you think that nursing theory should be more integrated into nursing education in practice? For example, by adopting one theory?
Is there more to that
No,
question?
that's the end of the
That's it.
question.
As a member of the American Academy of Nursing, I'm on the theory-guided practice research group. And this group of people, some are, the research theorists whom you have read from probably the 60s, 70s, 80s, like me in the 80s and beyond. And so I believe that, well, I'll put it this way. The philosopher Gadamer says that whether we use a particular theory that's been identified or not, we are always theorizing, which means to say that we're always seeking understanding of the nature or the meaning of something that we're encountering in the world. So our general way of thinking is constantly theorizing. So in the situation with nursing, nurses have identified specific theories associated with our discipline and our profession. And so I feel that to honor our theorists, that we should be cognizant of how to apply these theories in practice as well as in research. And any of you who work in hospitals know that the magnet system, especially magnet hospitals, you have to have a theory or a conceptual framework as a guiding framework for excellence in practice in these institutions. So subsequently, theory-guided practice is critical. So whether or not we, maybe a clinical team gets together and puts together a conceptual framework for guiding practice in their institution, or they use a specific theory, generated by a theorist, which has to make sense to practice, then you would use a theory. And so as a theorist myself and a teacher of nursing theory in the past, I believe that my responsibility as a teacher, professor, is to expose nursing students to all nursing theories and help compare and contrast various theories, and again, how they make meaning for whatever area that we're interested in or application that we are going to use in practice. And also, for example, on quantitative research, you always generally have to have a theory that guides the research, because you have to generate hypotheses from that particular theory and test those hypotheses, subsequently testing the theory. So I'm a believer that, for example, in science, we used to select a theory based on the next major movement in science. But complexity science, the new science, is showing us that multiple theories can exist together and paradoxically. And so I've always thought that nursing always took the leadership in that, because we always appreciated multiple theories rather than only one theory to guide our discipline and our profession.
Okay. Thank you, Dr. Ray. And I know we are just about out of time, and Jennifer had a few words to share with the group.
Yes, thank you so much, Shirley and Marilyn, and thanks to all of you out there listening today for joining us. Once again, please do take the time to respond to the evaluation you'll receive in your email, along with the links to the presentation. Your feedback will help us to continually improve the webinar program. That concludes our webinar for today. I hope you all have a great rest of your week. Thank you so much.